Chapter 57, Concepts of Care for Clients with Pituitary and Adrenal Gland Problems. The priority concept in this chapter is fluid and electrolyte balance. The interrelated concept in this chapter is cellular regulation. A person with hypopituitarism has a deficiency of one or more anterior pituitary hormones. This results in metabolic problems and sexual dysfunction. Decreased production of all of the anterior pituitary hormones is an extremely rare condition known as panhypopituitarism. Deficiencies of ACTH and TSH are the most life-threatening. They cause a decrease in the secretion of the vital hormones from the adrenal and the thyroid glands. GH deficiency alters cellular regulation by increasing the rate of destruction of bone activity, osteoporosis, and an increased risk for fractures. Hyperpituitarism is hormone oversecretion occurring with tumors or hyperplasia. The most common cause of hyperpituitarism is a pituitary adenoma, which is a benign tumor. As the adenoma grows and compresses the brain tissue, neurologic symptoms occur. This includes visual changes, headaches, and increased intracranial pressure. Prolactin-secreting tumors, or PRL, are going to be the most common. These inhibit the secretion of gonadotropins. This causes galactorrhea, which is the production of breast milk, amenorrhea, and infertility. Overproduction of GH causes acromegaly. This is going to result in enlargement of the hands, feet, and face, skeletal thickness, and organ enlargement. Excess ACTH overstimulates the adrenal cortex, causing excess production of glucocorticoids, mineralocorticoids, and androgens. We call this hypercortisolism or Cushing's disease. Drug therapy includes dopamine agonists to inhibit production of GH and PRL. We call these GH receptor blockers. For surgery, they can perform a hypophysectomy, and that is to remove the tumor and/or the gland. Immediately after surgery, you're going to advise the client to avoid any activities that increase intracranial pressure because that's going to delay your healing process. These are going to be like brushing your teeth, bending over, straining, coughing, or blowing your nose. Hormone replacement with vasopressin may also be needed to maintain fluid balance. You're going to teach the client to report the return of any symptoms of hyperpituitarism immediately. Diabetes insipidus and SIADH both cause disturbance in fluid balance. These are going to be related to either an excessive amount or a deficiency in the hormone vasopressin. So with diabetes insipidus, we have a decreased amount of ADH, and with SIADH, we have an excessive amount of ADH. With diabetes insipidus, or DI, I call it dry inside. That is considered if the urine output is more than 4 liters or is greater than the amount that is ingested. So these clients are dehydrated. A couple different causes here. With primary diabetes insipidus, that is a defect in the hypothalamus or the pituitary gland that results in a lack of production. With secondary, there's no direct defect. That can be caused by a tumor, head trauma, or infection. With nephrogenic, the kidney has a lessened response to ADH, and that can be due to kidney injury or disease. Drug-related is usually because of lithium or dicyclamine. DI will be treated with drug therapy, such as desmopressin, that can be taken orally or nasally. The synthetic for that is going to be vasopressin. With syndrome of inappropriate antidiuretic hormone, or SIADH, this is going to be a problem in which the vasopressin is secreted even when plasma osmolarity is low or normal. This leads to disturbances in fluid and electrolyte balance. Because water is retained, patients with SIADH end up with hyponatremia and fluid overload. Water retention causes urine volume to decrease and urine osmolarity to increase. So it's going to be more concentrated. At the same time, the plasma volume is going to increase and the plasma osmolarity is going to decrease. So it's going to be more diluted. Elevated urine sodium levels and specific gravity are going to reflect the increased urine concentration. Serum sodium levels are decreased because of the fluid retention and sodium loss. The increase in blood volume is going to inhibit the release of renin and aldosterone, which is going to lead to greater hyponatremia. Drug therapy is going to be with tolvaptan or conplaptan, and that's going to be used to treat SIADH when hyponatremia is present in hospitalized patients. These drugs are both vasopressin antagonists that promote water excretion without causing sodium loss. They're only given in the hospital setting so that serum sodium levels can be monitored closely. These clients can also be treated with hypertonic saline, 3% saline. That is used with caution in clients with severe hyponatremia with SIADH. With any type of fluid replacement, especially with clients with SIADH, we want to administer IV fluids cautiously because of the risk of fluid overload. These clients are already pretty fluid overloaded, and we don't want it to lead to pulmonary edema and heart failure. Moving on to acute adrenal insufficiency or Addison's disease. Production of adrenal corticosteroids may decrease as a result of inadequate secretion of ACTH, dysfunction of the hypothalamic pituitary control mechanism, or direct dysfunction of the adrenal gland tissue. Clinical signs and symptoms or manifestations are going to include muscle weakness, fatigue, joint pain, anorexia, nausea, vomiting, abdominal pain, weight loss. They're going to crave salt. They could also have some hypotension and hyponatremia. With Addisonian crisis, this is a life-threatening event in which the need for cortisol and aldosterone is greater than the available supply. A couple different causes here. There's primary, which is going to be autoimmune disease, TB, cancer, AIDS, sepsis, and adrenalectomy, and also drugs. Secondary is going to be caused by a pituitary tumor, also a hypophosectomy, radiation, and sudden cessation of long-term steroid use. Couple different diagnostic lab findings we have here. So ACTH stimulation test is going to be the most definitive test for adrenal insufficiency. We give this IV. ACTH cortisol levels are tested at 30 minutes and again at 1 hour. In primary insufficiency, the cortisol levels do not increase, and secondary, the cortisol levels would be elevated. So again, this is going to be the most definitive. A lot of these other tests are not going to rule out other diseases. This one is going to be specific to Addison's. Your interventions, you're going to monitor for and prevent hypoglycemia, as that is a medical emergency. Monitor their INO, monitor and treat for any hyperkalemia. Again, a medical emergency, so cardiac monitor, EKG if necessary, replacement of cortisol and aldosterone, and wear a medical alert bracelet. Cortisolism or Cushing's disease. With this, the adrenal gland may oversecrete just one hormone or all of the adrenal hormones. Hypersecretion by the adrenal cortex is going to result in hypercortisolism, and we call that Cushing's disease. You may also see this referred to as hyperaldosteronism or excessive production of androgen. This is going to affect metabolism and all of the body systems to some degree. The most common cause of Cushing's disease is going to be a pituitary adenoma. Clients with hypercortisolism, they're going to have physical changes such as the fat pads on their neck, back, and shoulders. We call that the buffalo hump. Enlarged trunk and thin arms, and face is going to be round like a moon face. These clients are also going to be prone to hyperglycemia and hypertension, and emotional liability is very common. So what that means is they're going to have a very quick temper, so they're going to be upset quite quickly. For labs and diagnostics, we have blood tests, urine, and saliva. With the dexamethasone suppression testing, we're going to give a set amount of the dexamethasone, followed by a 24-hour urine collection. And if the cortisol levels are suppressed, we have no Cushing's, so we would need to look for another cause. So that helps rule out Cushing's disease. We can also do imaging, but the cortisol levels and the dexamethasone suppression are going to be more definitive. The cortisol levels in the blood and the urine are both going to be elevated. For your nursing interventions, be aware that these clients can go into fluid overload, and that's due to hormone-induced water and sodium retention. Potential for injury is going to be huge with them, especially related to fractures. So we want to prevent falling. And then infection is also a major concern with them. So we want to practice good hygiene and instruct these clients to avoid crowds. So here are our goals for our clients. We want a reduction of plasma cortisol levels. We're going to be removing any tumors if they're present, restoration of normal or acceptable body appearance, monitor the patient for response to drug therapy, and safety and infection. So for these, we're going to monitor the patient for response to drug therapy, especially related to weight loss and increased urine output. We want to observe them for any signs and symptoms of fluid and electrolyte imbalances, especially with EKG patterns. We're going to assess their lab findings frequently, especially the sodium and potassium values. A major objective for these clients with hypercortisolism is protection from infection. So hygiene is going to be a concern here. And the clients that are going to be most at risk for acute adrenal insufficiency are going to be the ones who have Cushing syndrome as a result of drug therapy. So glucocorticoid drug therapy. For treatment, drug therapy involves the use of drugs that interfere with ACTH production or adrenal hormone synthesis for temporary relief. In clients with pituitary adenomas that are causing Cushing's, there's a surgical treatment that will remove the adenoma, or a hypospectomy, or a partial or a complete adrenalectomy. Moving on to hyperaldosteronism. In hyperaldosteronism, we have an increased secretion of aldosterone. Aldosterone is going to regulate your levels of potassium, sodium, and overall blood volume. High levels of aldosterone can result from a condition called primary aldosteronism, or PA, which causes a high blood pressure. PA is also known as hyperaldosteronism or Conn syndrome. Primary aldosteronism, the PA abbreviation called Conn syndrome, that's going to result from excessive secretion of aldosterone from one or both adrenal glands. This is usually caused by a benign adrenal adenoma that's going to result in mineralocorticoid excess. In secondary hyperaldosteronism, the excessive secretion of aldosterone is caused by high levels of angiotensin II that are stimulated by high plasma renin levels, and this causes excessive vasoconstriction. So these clients are very prone to hypertension or elevated blood pressure, which is going to increase their risk for strokes, heart attacks, and kidney damage. Signs and symptoms or clinical manifestations are going to be your 3 Ps, so that's your polydipsia, your polyuria, and your paresthesias. So polydipsia, excessive fluid intake, they're very thirsty. Polyuria, they're urinating a lot. And the paresthesias, that's going to be the numbness and tingling. That's going to occur if potassium depletion is severe. Moving on to pheochromocytoma. Pheochromocytoma is going to be a catecholamine-producing tumor that arises in the adrenal medulla and produces, stores, and releases epinephrine and norepinephrine. These clients often have intermittent episodes of hypertension or attacks, and these vary in length from a few minutes to several hours. And a lot of these symptoms, the signs and symptoms or clinical manifestations, are going to be associated with that hypertension here. Precautions for these clients: we don't want to palpate the abdomen and do anything to that pheochromocytoma. Diagnostics, we're going to do a 24-hour urine. The treatment for these is going to be surgery, and these clients are going to be on hormone replacement for the rest of their life. We want to notify the doc of any signs and symptoms of infection, and do not stop those steroids abruptly. And this includes the recorded lecture for Chapter 57, Concepts of Care for Clients with Pituitary and Adrenal Gland Problems.